Hi, YouTube. I don't normally do a pre-recorded video at the beginning of these things, but I didn't know the best way to put it out there. There are some amazing questions that my residents asked at the end of this video. Of course, they'll all be timestamped as normal. I know some of you probably will cut off when it goes to the Q&A at the end, but if you're interested in this topic at all, and I highly suggest that you do become interested in this topic, make sure you watch to the end and listen to those good questions because it really does explain some of the things that I feel like I missed and didn't do as well of a job as I could have. And as always, if you have any questions, go ahead and drop a comment below. Let's go ahead and get on with the video. What we're going to go over today is the final one in the non-clinical how to determine your anxious patient one. Where's my actual video? Hopefully that works. Okay, can you guys see everything? Awesome. Okay, let me pull this in here so that that's there. Okay, cool. Actually, that works out beautifully. Alrighty. So what we're going to do is finish up today with the kind of like how to identify patients who might have some hyperinflammation, might need a little bit extra TLC. If we have time, we'll go through some example cases. If not, what I'm planning on doing is just maybe at the beginning of each lecture, starting at each month, we can go through kind of an example case, how I view them, how I see what's going on. You guys saw the text message from me. My first patient today, I wasn't able to work on her because she had such a bad gag reflex, and that is because of the airway issues that she has. If you can't breathe through your nose properly, if you have a big tongue tie, it's going to cause some issues as well. So what we're going to do is go through all that. Any questions for me before we get started? Sweet. So let's go ahead and get going. First off, we're going to go back in time. And because it's me, we're going to talk about food. If you haven't seen this, this is probably one of my most favorite lectures I've ever put together. I don't know if we'll be, doing this one, if I'm going to be giving this one to you, but it is on YouTube. It talks about how important it is to give a high quality of service to your patients. But I love food. Anyway, we'll start off here with the oldest jaw that we have, which is 1.3 million years old. And with this jaw, they have things like perio, calculus, hypercementosis, something called toothpicking wear facets, but there's no caries. So caries is actually not that old of a disease. And if we go to what caused that, some people think, okay, it's fire, that when we had fire come along, now all of a sudden we can change how we prepare our food. So we chew differently, we eat food differently, get different nutrition. What it did do is made it so that it doesn't take us as long to get the nutrients out of our food, which led us to be able to put more energy towards the brain. That's one of the ways that Homo sapiens took over from the other types of hominids, is because our brains were larger due to our ability to cook food, which means we're able to get more nutrients out of them. The interesting thing is, even though 50% of their calories were from carbohydrates, there were still no dental caries. So let's go to the first known case of dental caries, which was only 80,000 years ago. And it was from not toothpicking. So you've got to floss. That's what it really comes down to. We had a great lecture, the whole 2-day thing in Chicago at the ADA this summer, and the moral of the story was, if you don't floss, you're going to die. That's pretty much what it comes down to. But I love this, that they're shaming this dead guy who's been around, he's 80,000 years old. He was ignorant of his tooth picking, which was known in other hominids. But this is the first time that we see caries pop up. And the reason why, and what they kind of suspect, is that dental caries is associated with the rise of civilization. So because we're able to further process our food, it's easier for the bacteria to break it down, and that's what causes dental decay. Now, what about malocclusion and kind of the jaw issues? And when we look at it, this is a fantastic study that was done back in 2009. And the conclusions were, it wasn't the reduction in tooth, actually I can't even read that because your thing's in top, it's tooth wear, that caused the crowding and the malocclusion, but it was that we weren't having to chew as much. And so what they proposed is that ortho shouldn't be looking at doing things like IPR and tooth extractions to get to a class 1, you should look to increase the dimension of the jaw. And back in the early 1900s, that's actually what orthodontists did, is they didn't have any brackets. They didn't have any way of moving the teeth. So the original ortho, before it became a specialty, people who kind of said they were orthodontists would work on ways to use different, what we call myofunctional therapy today, to increase the size of the jaw in children so that there's space for the teeth to come in. We'll get to why this is important in a second. And once again, we've known this now for 15 years. How do we get from this guy to this guy is really what it comes down to. And by the way, the guy on the left, you guys have, hi, I'm from the internet. You've all seen this guy, right? The meme of the giant jawed man. He's actually a real person. He's not made up. He just doesn't, he's in Russia and doesn't want to do anything. He's like a bodybuilder out there. But yeah, he's actually a real person. But how do we lose all that development? Well, and what is it, what's the consequences of it? I'm going to use the dogs as an example. So this is my dog, Penny. Louis is down here somewhere, sleeping in the corner. And you'll notice she's breathing with her mouth open right now. And that's because we had just gone for a long hike. It was hot outside, so that's how dogs cool off. 99% of the time, this is what Penny looks like. She's breathing through the nose, giving me a judgmental side eye. There's a great study that was done recently on dogs, and that if they're female dogs, they're more likely to actually judge you. And this dog judges me all the time. I love her very much. Take as the opposing dogs that we have bred to have very short faces. So pugs, bulldogs, things like that. Notice they're always breathing with their mouth open, and that's because they can't breathe through their nose. For those of you who don't know, I think I mentioned this in one of the earlier lectures, my brother's a vet. And anytime someone wants to buy a Frenchie, he tells them, start saving now for cancer treatment. So the best part is I was making this presentation and I sent it to Craig and I was like, hey, can I use this quote? And what you'll see is, yes, but they need to start saving for airway surgery, hiatal hernia surgery, back surgery, and then if they survive all of that, cancer. I love my brother very much. But notice what he said here, that airway surgery is part of that kind of domain of things that go on. So what happens when we breathe through our mouths? In kids, that's when it's most important, because if you breathe through your mouth, your tongue isn't going to get into the right spot. And you can you guys all read the things in here? Crooked nose, open mouth posture, receding chin, forward head posture, poor definition of cheekbones, setback jaw, narrow face, all those things. So breathing through your nose is so important. And once you start to realize this, it's going to be one of those things where you cannot unsee it. You're going to walk around and realize everyone's walking around like the people at I tend to go to like if I have a cracked tooth in the morning, it's a perfect time for me to go to Costco because it's an hour away or it's a mile away. So I will go in there and you see all these old people just walking around, staring up, open-jawed, not knowing where they're going, because that's the only people who go there, besides me at that time. And what this comes down to, and a lot of more progressive orthodontists are subscribing to this theory, that what we need is a bigger box. So we need more space for the tongue in order to breathe properly. And so what we're going to do is look at me. This is my cone beam, and I think hopefully the video works, maybe? Nope, it does work. Okay, cool. This is going up and down my airway right here, and you can see these are not good numbers. The minimum amount was 68.3 millimeters squared, which is about that big. I'm 6'4" and trying to breathe through that tiny, tiny, tiny space. And what happens is the tongue is going to go into the airway if there isn't enough space in the mouth. This is where we're developing so many of these issues. So let's talk about me. This is me at 6 years old. I took this from my parents' house. My mom has all the, fun different photo albums and things like that. But around 92, 93... I was very class 3. I had a pretty strong lower jaw, but I was set back in the upper. And so what they did at that time is they gave me a little mandibular device to slow my growth so that the upper jaw could catch up. After that, things really weren't that bad. My second year of dental school, right after taking occlusion, I started doing Invisalign because all of us did after going through occlusion. I think this is pretty common. And I had a little bit of anterior crowning, but my This is a classic example of never let the people who invented the thing use it on you. This is when Invisalign had only been out for a few years, and the orthodontist who had consulted on it was my orthodontist. So what he did was just keep experimenting on me and trying all sorts of new things, and it didn't fix any of the problems. I should have done traditional brackets way back in the day. It's fine. So I still had a open bite, terrible occlusion, but at least the teeth were straight. From 2014 to 2020, I probably due to stress of dentistry, I sheared off all the cusps of my canines that we have replaced with composite, but that is straight up from clenching. And then in September 2016, I went to see this man, Jeff Rouse, at a Spear seminar. I had been following his stuff since about 2011 on a Google groups that my friend's dad was a part of. So I knew some of the things. And back in the early days, the only way to really fix this was to use something called a mandibular advancement device that would pull the jaw forward, giving you more space. They worked, but they had a ton of complications. So things like huge posterior open bites, you can have jaw pain, lots of issues with it. And after that seminar, I realized, oh God, it's me. I am the patient that they're all talking about. I'm the problem. So I decide to try and start to fix some of these things. So here are all the things that I have tried over the years. I've had my tongue has been cut twice in my life so far. Once when I was a day old, once in 2019 by the oral surgeon. We are rescheduled for a third one after I'm done with what I'm working through right now. I've had Vivera nose remodeling where it expands it and redoes the nasal valve. That's been twice. It had failed, which if you ask any ENT, that's what they all do. But my revision actually has been stable. So I've had to have it twice, but that made a huge difference in my ability to breathe. I've used mouth tape and clear spray since 2016. I've had multiple different oral appliances. I first made a quick splint, then I made a MyTap, and then I made multiple. I've had people make me multiple mandibular advancement devices. I have had lasers on every aspect of me. I've had myofunctional therapy, and none of it really seems to be making a difference. I've also tried everything that I talked about. I've gone to the gym every single day. I've tried all the supplements you can think of. I literally cook all my food from scratch because I'm weird like that. I don't eat processed food. I do intermittent fasting. I've tried no alcohol for a month. I've done all the sleep hygiene things, and still nothing works. So what it came down to, my rock bottom moment, was January 3rd, 2020. I know this because that was the first day that I saw a patient. I'm 32 years old. I had just opened my new practice, and I was flying back. I got a phone call from a good friend who's like, hey, I have a friend in town. They have an emergency. Can you see him? Sure. I'm flying back, so let me see him in the afternoon. I'm on the plane with my 3-month-old baby at the time and my wife, and I pass out. Like completely pass out. Vanessa's yelling and screaming and hitting at me, and I am completely out of it. So I go to the doctor, and I have hypertension bad enough that most dental students wouldn't treat me. I get to have the big old obesity number thrown at me. I have hyperglycemia. I have hypocholesterolemia. Somehow I do have good HDL, which I think is because of the diet that we primarily use olive oil and everything. I think that's where it comes from. And this is metabolic syndrome, what we just went through. I'm 32 years old, very healthy. What the hell is going on? Mostly it's sleep issues. I started snoring probably around 28, 29. So I go to the doctor, and this is the rough representation of what she looked like. To be fair, if you've had to go through the American medical system, it's the biggest pile of shit in the world. We spend more on medicine and are sicker than anybody else by numbers that are absolutely unfathomable. It was 3 months to get in for an initial visit, and no one would see me. So I went around the system because that's what I do. I have a good rheumatologist friend who teaches at UNR, and he's like, I can get you into the internal medicine residency clinic. You're good to go. And here's what I was told. I told them all this. But the first thing is, you're too young to have these problems. And my response was, no shit. That's why I'm here. They said, just lose 10 pounds. And I did. And it didn't make a difference. And they literally said, well, we don't know how to calculate your risk because it starts at 40 for cardiac issues. Here's a fun fact. 1 in 5 heart attacks are in patients under 40. And in men, half of them are fatal. So I am an asshole. And I literally said, if I start smoking, will you finally treat me? because that is the one way, by the way, that's the one way you will actually get treatment is if you use tobacco products. If you're a smoker, they will actually start to treat you. I didn't. I still haven't ever had a cigarette in my life, but that was that was my line to finally get some treatment. So they started me off on baby doses of lisinopril. Finally got up to where I'm on now 40 milligrams of lisinopril, 12.5 of hydrochlorothiazide, and I am at this point mostly stabilized blood pressure. I still had some high peaks and valleys then. But I'm really frustrated because I live a healthy life. I have done everything that's right, and I still have all these issues. So, by the way, if you are ever needing care for yourself, trying to get into an MD is next to impossible, but PAs are much, much, much easier to get into. They know enough to take care of the more simple issues like hypertension, things like this, and they can get you into a medical doctor a lot faster. So just a pro tip there too. If you're, oh my goodness, hold on a second, guys. Hi, Daddy's talking to the residents. Come here. Sorry, my wife brought my little girl here, so everyone can say hi, Tutu. Tutu. Yeah, say hi, everybody. Can you wave at the camera? Yeah. Okay. Hi. Okay. I gotta go keep talking. As that was not planned. But everyone loves seeing a cute little kid. Speaking of my wife, sorry. Uh, so then I decide to go ahead and do a CPAP. I absolutely hate it. Can't tolerate it whatsoever. Um, by the way, don't have these conversations with your patients. They're like, I'm here for the root canal. And don't have them with your spouse. My lovely wife, who just showed up here, also has some very slight symptoms. And I told her starting in 2016, like, hey, you could really benefit from mouth taping. I think it would make a difference. And she's like, no, I'm going to suffocate. I don't know what's going on. So she now mouth tapes every night and sleeps much, much better. Does anyone know why she started doing it?
To make you stop talking.
No, 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 no. It was a influencer on TikTok who told her it would improve her jawline. I literally study this and talk about it, and a 17-year-old influencer on TikTok has more influence than I do, so it's fine. So what does all of this come down to? Really, it's the ability for us to breathe, and if we can't breathe, what it does to our sleep. These are two absolutely fantastic books. They're literally right over there because I have them. I highly recommend if you haven't read them. Why We Sleep talks about the issues when we don't sleep, what happens from it. Breathe talks about how important it is for nasal breathing. He actually did a fascinating thing where he plugged his nose for an entire month and saw what happened. And he gained 20 pounds. He was hypertensive, pre-diabetic in a month. And just by switching to nasal breathing, he was able to fix all of that. So really interesting. The ADA is also involved in this. This is what I was talking about, where we did in Chicago. They had a fantastic thing on the ADA, the dentist's role in complete health. I actually got an email this morning talking about the Good Energy book that I was telling you about. There was the author is going to hopefully speak before Congress and do some of this stuff. While I was at that, I did go to a 2 Michelin-starred restaurant because, of course, I do love my food. But what everyone has thought is that if you are fat, you then have sleep apnea. And what it's more likely actually going to be is that sleep apnea causes the obesity. And even more than that, that if you start to have difficulty breathing properly, this is where you're going to get all these issues. So even though I was doing everything proper that I was told to do, I ate well, I exercised, I tried my best to sleep, I had good sleep hygiene, I still had metabolic syndrome. And if we remember from last time, in males, it's much more likely to present as metabolic syndrome due to testosterone. If I was a female, I'd probably have more of the anxiety and hyperinflammation that we would see. And this is more of the patients that you all will be seeing as well. So if you've ever seen, this is in every airway office you'll ever seen, that usually it starts off where you have some slight snoring, but this is a progressive disease. And so it's not okay to be snoring. That's the, canary in the coal mine that something else is going on here. So at this point, no one's treating me. I'm still having issues. And I finally said, enough is enough. which, if you haven't known, I had my face cut open and a bunch of bones shoved into it. So this is a process known as surgically facilitated orthodontic treatment, or SFOT. So periodontist, actually, Nate is a SLU resident, or SLU graduate, went in, made these vertical cuts in my bone, and then I had a local sleep doc make me this appliance. And what we're doing is we're widening this one, and I wear this lower appliance at night, and it pulls my upper jaw forward. And we got some serious movement. So I am actually now almost 3.5 inches from cusp to cusp. You'll notice this is out though. We've expanded me about 4 millimeters, and I've gained about 2 millimeters of anterior movement. And that's because I was a little too good at doing my movements, and I now have, this would be called getting out of track. My second molars are way far out compared to the rest of them. So I had a scan done recently, and they are remaking a new appliance to push the rest of the teeth out there. Now, what all this gave me was, without changing any of my habits, I dropped 25 pounds. So I'm just on the border of that BMI of 25, which is overweight. So I'm still I'm close. I have a little bit more to go. My blood pressure has stabilized to the point that I'm starting to have actually low blood pressure symptoms. I'm usually right around 100/70 now. So I need to talk to them about maybe dropping down some of the medications. And I don't use my CPAP anymore. So by fixing the breathing issues, instead of just putting bandages on top of it and getting to the root of the problems, I'm actually fixing all of this. What you will find is that pediatric dentists get this 100,000%. Go over to the pedo clinic after this and say, we just learned about Airway. What do you guys think? And they will talk your ear off for hours and hours and hours, because that's all they're focusing on. Because this is why it's so difficult to treat this. I am doing this all myself. There's no insurance company that'll cover it. I have already spent my out-of-pocket, and the dentists aren't charging me for their time. I've already spent close to $2,000 just on the treatment alone for the bone, the membranes, the appliances, everything like that. If I did this out of pocket, I would probably be close to $20,000 out of pocket already, just because of all the time that I would have had to give to all these people. Periodontists also seem to get this. The ones who don't seem to get this as well, and I need to be careful with how I say this, are the two ones that can make the biggest difference, which are orthodontists and oral surgeons. They tend to be very against this. How many of you guys have seen or heard of this documentary? Anybody? Yes? No? Nobody? Go ask the orthodontist about it, because to them, it's as bad as this documentary. And I realize why they don't like it. The orthodontists in Open Wide are just complete douchebags, but they do have a really good point, which is we have to stop pulling people's jaws back because we're causing so many of these issues. The root cause one was just a stupid thing in the first place, and it's garbage. The reason why I bring up this is why they should understand this, because do you guys know there is a treatment, a permanent treatment that fixes everything for sleep apnea? Do you know what it is? Throw something out. Nothing. Guys, the dental students were more engaged yesterday. It is hard being. It's maxillary mandibular advancement. You move them 1 centimeter anteriorly. That fixes 100% of OSA cases. 100%. The other one that will actually treat it is if you trach them and have it bypass the mouth altogether. But I didn't want to walk around with the permanent trach. That sounded terrible. So, like I said, there is some opposition to this. This is available. This is on Spear online. This is by Jeff Rouse, and he talks about, back in 2016, the AAO put out this white paper on ortho and the airway, and it was definitely contentious, to say the least. If you're interested in this at all, which I highly recommend that you do start to look into it, this is a great paper that kind of talks about the discussion of the connection between airway, orthodontist, general dentist, and what we can kind of do to help our patients. So I hear all of you, and by the way, once again, the dog's giving me judgy eyes. What does all of this have to do with endo? Well, here are the issues when people don't sleep. It's associated with increased activity of the sympathetic nervous system. The HPA gets sensitized. There's metabolic effects like we talked about. And the issues in circadian rhythms we already know. But the most important one for us is that there's pro-inflammatory responses. So our patients who don't sleep well are going to have more pain, they're going to require more anesthetic, and they're going to need more post-op care. So learning to figure out who these patients are is going to make all of you better endodontists. For short term, which can happen when people are in a lot of pain, you see things like they're going to be more stressed. They're going to have somatic pain deep down inside. They're going to have the reduced quality of life, which we know. They're going to be in distress. They're going to be pissy and angry with you. And they're not going to be able to remember all of these things. In kids, you still have these same problems. They're not going to be as healthy psychosocially. They have issues in school. They're going to take risks. In pediatrics, which is interesting, you're going to have behavioral problems and issues with cognition. And I bring this up because my oldest is currently going through something to help her jaw develop because she also has some behavioral problems. Her cognition is the problem is she's way too smart. But the emotional reactivity is off the scale. She was screaming at us this morning because she doesn't sleep well. And so we're already starting to fix it now so she doesn't have to go through the same thing I did of cutting my face open. So what happens when we can't breathe? Well, let's talk about what we actually breathe in. So these are the numbers for inhaled air and exhaled air. And when you look at it, what you see is an exchange for oxygen and carbon dioxide. We know this. This is very obvious, okay? Do you guys know how long it takes? How many of you, did anyone here do a GPR where you got to intubate people?
I did.
You did? Did you do it?
Yeah.
How long did you have before they started to worry about airway? So they give the paralytic, and then you got to get it in there. How long until they took over because they were worried about the patient starting to desat?
Pretty quickly, if need be.
If need be, but yeah. But you had about a minute, right? It's not like you need to be in there immediately. Like a minute or two?
Yeah.
Yeah.
I'd say that's fair.
And that's mostly if you talk to dental anesthesiologists, just if they're ASA 1 through 3, you're going to be able to get that in there within about a minute to two. And that's when you'll start to see it start to desaturate, not start to die, just start to desaturate from 100% or 99% oxygen saturation. So let's play a game. After this, I want all of you to go find the pulse oximeter in the clinic. Put it on and hold your breath until you start to see it desaturate. I can almost guarantee none of you are going to make it to the point where it starts to desaturate. And that is because the issue isn't enough oxygen, it's too much carbon dioxide. And what happens is if our patients are chronically walking around hyperventilating, what's going to happen is you're going to get rid of more carbon dioxide than the body can produce. And if you mouth breathe, you're going to have the hyperoxygenation, and you're going to have hypocapnia, which is a low amount of carbon dioxide. If this becomes chronic, you're going to have more anxiety because anxiety causes you to breathe faster. And when you breathe faster, it causes anxiety. Think about the patients who are anxious. When you go to get them numb, what do they all do? And we'll talk about in just a second why that's a problem. When you have this chronic hypocapnia, you can get all these fun things, like the cortical neurons just fire for no reason. The neurons are going to be more excitable. The muscles are going to be more excitable. This is why it's so much harder to get these patients numb. And so what happens when we have the proper amount and we nasally breathe and CO2's at the proper level, it's going to make the pH more normal. It's going to dilate your capillaries so you get better blood flow. You could actually have a narcotic-like effect that's going to calm down the excitability of the nerves and muscles. We're going to go through an exercise in just a second where all of you get to try this. It's amazing how well it actually works. And it's going to, it does all the good things that we want it to do. So let's go ahead and do a quick test here. This is how to breathe for anxiety. And there's a star there because you can either breathe to create anxiety and inflammation, or you can breathe for anxiety to decrease it. So we'll start off with the decreasing it. How many of you listen to Huberman? You guys don't know who Andrew Huberman is? That's what I thought, yeah. Do you guys all know the physiological sigh? Yep. This works incredibly well. So what you're going to do is take 2 small inhales through the nose. So And then one long exhale through the mouth. Everybody try this. Do this a couple times, and you will probably feel your body start to relax. It is one of the most impactful things. If I have a stressful patient, or if I can't find MB2, or if something goes wrong, I will take a moment and I will literally do one of these. I'll just sit there, eyes in the scope, not anybody looking, pretend like I'm still doing something so the patient doesn't get weirded out. And it's 10 seconds max to just reset, because one of the things you'll learn is how important your mindset is for doing good root canals. If you're stressed out, you are not going to be performing at the highest level. So this is something I literally do this probably every day at this point. It's a very, very useful tool. But how it works is it's going to increase the parasympathetic nervous activity. And if you remember those two charts of what we want, most of the time we're walking around chronically firing those sympathetic neurons. So increasing parasympathetic nervous activity is going to offset that. So if we have, these are kind of the two different ways that we can breathe. Short inhale, long exhale, long inhale, short inhale. This is one on the Huberman side is going to increase your parasympathetic activity. The other is going to increase sympathetic activity. It's going to reduce stress, blood pressure, and anxiety versus increase epinephrine levels and immune response, which is exactly what we don't want 99% of the time. How many of you guys know who this guy is?
Wim Hof.
Wim Hof. Very good. He's also a giant asshole if you haven't listened to the Behind the Bastards on him. However, he developed his way of breathing is called turbotidal breathing. I can't even remember the name. It's a funny name, but it's a way in which you can breathe to increase your immune response. And he's done some crazy things, like climbed over Mount Everest barefoot. He ran a marathon down in Antarctica like this. He has world records for the longest, cold water exposures. And so what I'm trying to show you is the way that we breathe is incredibly important. And when we're looking at our patients, that's where you can catch a lot of this. So how are you all going to go in the next 25 minutes, go to see patients? What can you take away from this? Well, I want you to add a couple of things to your examination, and it's things that you're probably already doing. You already take a look at the x-rays, take a look at the teeth, you look probably around the area, you do your oral cancer screening, all sorts of things like that. But how many of you look at the nose? How many look at the nose to see if the patient can breathe properly? It's very easy. You don't have to tell them to do anything. You just take your mirror and you move it out slightly, and what do you know? You can see the nose. How many of you think she's breathing great? How much happier do you think she is after having the nasal surgery done to fix the breathing? My very first patient today, the one that was gagging, I told you all we were going to talk about, her nose looked like this. I'll show you pictures of it after we're done if we have time. This is what this is. And sure enough, take a look at the nose. You can see it right away. What about the jaw? Take a look at them inside. And so this is the trick that I have. I'm not sure how you guys will be able to do this, but when I walk into the room, I'm right-handed, so I'm on the right-hand side, patient's on the left and the center, and then I have the assistants give me kind of a summary of what's going on. So they'll say, this is, Mrs. So-and-so, she had a crown done recently, she now has cold sensitivity, she's tried this, blah, blah, blah. And so what I do is I introduce myself and I motion, and what they do is they turn their head. And that's when I'm able to look and see, where's your mandible? What's going on here? Where's your maxilla? And these are pre and post-op pictures I got off the internet for orthodontic surgery. But this doesn't take any additional time to add on to your exam to take a look and see, is there a potential airway thing? And I'm sorry for doing this to you, because once you see it, you're never going to be able to unsee it, and it's going to drive you absolutely crazy how many people are walking around with airway issues. The other one is forward head posture. You'll see a lot of people, in order to breathe, will push their head out really far like this. That opens up the airway so they can breathe, but what do you think it does to the muscles? Our head is actually quite heavy, and those muscles aren't designed to have it hanging out over there. So what you're going to see is a lot of pain back in occipitalis. You can have the SCM start firing like crazy. You can even have the masseter start going here. They're going to have a lot of headaches. They'll have psychosomatic pain. They're going to have a ton. Actually, if you guys do the SCM on your muscle exam, you'll find all the time that it is full of trigger points that causes them extreme amounts of pain. I tried to get I couldn't get the picture, but Evie is exactly this way. She has really huge adenoids right now, so she can't breathe properly. So she has really bad forward head posture, which is why we're doing a lot of things to fix that. So during your muscle exam, if you're just going to do 2, these are the biggest ones by far. You want to palpate your masseters, and you want to palpate the temporalis. Usually it's just the anterior temporalis that causes issues. I don't go all the way back. But the masseter I do every single time because you're going to find it is full of trigger points. And what you want to feel is those trigger points, they're going to feel like knots, like when you're massaging someone's back. And what you want to do is push and hold with 4 pounds of pressure. So you're all asking me, Scott, what the hell is 4 pounds of pressure? Well, if you have a digital scale, you can figure it out real fast. But the cheating way, put your finger on the desk and push down until it starts to blanch. That's about 4 pounds of pressure, give or take. So it's more pressure than you think. And what you want to do is find those knots, push and hold. And what you'll often find is that all of a sudden the tooth hurts. And that's usually when they get the aha, I don't need a root canal. There's something else going on here. And what you want to see is how big they are and how many trigger points there are inside there. Once you start doing this, you'll be amazed by how many people are walking around just chronically clenching the crap out of their teeth. Talking about the frenum, like I said, I still have one, even though it's been cut, because that little bastard just loves to come back. If you can't get the tongue in the right position, what's going to happen is your airway is going to be blocked. You're going to have issues with if it's not on the roof of the mouth, it's going to cause your jaws to grow improperly. In my case, what happened was I was tongue-tied for the first 20-ish plus, or how many years of my life. And what that did is it meant that my lower jaw grew faster because the tongue was stuck down inside there. And my upper jaw didn't have a chance to grow because the tongue wasn't causing that issue. So I already know what caused the issue way, way, way back when, which is why we've done so many things to get my tongue into the right spot. So when you have a proper tongue position, you can breathe, you can have you'll look better by, I have improved how I look by doing these things because I finally have a chin. my upper jaw is starting to grow into the right spot. I still have a little bit more to go, but it's in the right spot. And so start looking for lingual frenums that are tight or tied. What you will start to notice is that they are all over the place. First patient today also had a huge tongue tie. Tongue ties are 100% associated with gagging issues. So she can't breathe through the nose. Her tongue is super tied, so it's already all the way back there. And then I go and put all this crap in there to try and do her root canal. That's why she's coming back on Halcyon, because she's not going to care about all of that. It's not going to fix her airway. My job is to fix her tooth. I can fix her tooth. My job isn't to fix the airway. On some people, if they're interested about it, I will start to educate them. But I made the mistake of, once I saw this, started telling everyone about it, and they literally treat their sleep like it's a possession. I sleep fine. What are you talking about? Okay. I learned my lesson. But I'm trying to give you the tools to identify the patients that are going to be more at risk at having inflammation. Other thing, if you look in there and all you see, they open your mouth and this is what you see, a tongue protruding over the side and causing all these issues, guess what? They're gonna be a problem.
You're gonna have a bad time. Also be aware.
If you put your mirror in there and the first thing you see is, that means they're mouth breathing. They're not breathing through their nose properly. Another sign that you want to look out for. So, how do we treat all of these things? I just want to let you know, but this isn't something we will be doing. In general, you're gonna, let me rephrase that. This is things that you can do to make a difference. So we have different night guards that we can make them. We can give them some exercises, which is a form of myofunctional therapy, and we can give them different drugs to help with their pain. For quick splints, they are a wonderful, wonderful tool. I have done some research for them in the past, just to full disclosure, things like that. They did give me some free things, but it's been 8 years since that happened. I still make them all the time. They're really amazing devices. How they work is that little piece of plastic that you see right there. You test fit it inside the mouth. You put blue mousse inside the quick splint, pop it in there. It takes, 10, 15 seconds to set up. You take a 15 blade, trim it back, and they're good to go. And what this does is two things. Number one, generally we're going to see more pain on posterior teeth just because of physics. You're able to create a lot more force at the back of the mouth than you are at the anterior portion of the mouth. So think about when you use scissors. If you got to cut through something heavy, you're putting it back as close as you can to the fulcrum. The fulcrum in the jaw is the joint itself, which is why you're usually going to see these on second or first molars. By opening that, now at night when they do most of their clenching, they're not going to be aware of it. And then the second thing is there's a great study out of the 1980s by a man called Arturo Mans, and he took all of these night guards and cut them up into different pieces. And what he found is that if you have a full night guard, you can actually increase the force of your muscles by about 25%. So this is a fun the prosthodontist will know this, but if you increase VDO, you're going to increase the amount of force the muscles can create. However, if the occlusion is only on the anterior portion of the mouth, it reduces it down to about 20% of the total maximum that you can do without having a night guard there in the first place. If you've heard of an NTI appliance, this is the concept behind that. Now, some of you may hear that NTIs are really dangerous, and there's two reasons for that. Number one, some people like them so much that they wear them 24 hours a day because it helps so much with their headaches. If you do that, you eventually will start to cause forces and push the two teeth up inside there. And the other thing is this small fine print in that study. It's not 100% of patients that have that reduction. There's about 5% of them that can still create just as much force in the anterior. So the way you test for this is you take your bite stick, put it between the front teeth, hold your hand on the masseter, have them bite down, take it out, have them bite again. If they're the same, this is not a good device for them, but for the vast majority of patients, it's a wonderful tool. They're inexpensive. We make a lot of these all day long. So ideally, you want to have the tongue on the roof of the mouth. You want to breathe through the nose. That's what we want to try to teach patients to do. I can send you guys the little sheet that I have my staff go through when they work with patients as far as how to do these things. But this is a big concept called myofunctional therapy. If you are not familiar with it, find a hygienist. They seem to love this more than anybody else. Hygienists are great allies in the fight of getting people to understand airway. This is who you're going to probably learn most of your myofunctional therapy stuff from. You can also look it up online. I also have a video that we send out to patients showing how I videoed Jenny doing it, and it shows you how to actually do the exercises. So I can text you guys that as well. As far as the different medications we're going to use, we'll go into that either in the next lecture or the lecture after that when I go through all of pharmacology. But generally, I'm going to give them either a steroid or a muscle relaxer to help either make them sleep better or help reduce inflammation. So let's go through a quick example patient. Oh, we're doing good on time. This is a 72-year-old female, and look at that med history. What do you guys take away from that, given what I taught you last time? Hopefully you remember it. Do you remember what happens to women when they go through menopause? The young, fit female turns into the fat old dude. So what do we see in here? We see high blood pressure. We see cardiac pacemaker. We see irregular heartbeat. We see gallbladder troubles. We have serious illness. They're taking medications. They're on lots of different medications here. They have... I want to know the people who know that they're allergic to acetylcholine and Dilaudid. She's had a history. This should be a red flag right here. Like, something happened. Most people don't know what Dilaudid... Does everyone here know what Dilaudid is? Dilaudid is what Oxy wishes it could be. It's one of the most potent and insane painkillers that makes everybody feel amazing, except for her, apparently. Radiation. She has other disease. And, of course, she has a latex allergy as well. So these are the x-rays. I'm not going to tell you which tooth. I think it's really important to go in blind. Which tooth is causing her problem? Can anyone see a tooth that's standing out that could be an issue? Are the x-rays coming through on the screen? I know sometimes they don't do great on projectors.
Yeah, they look fine.
Okay. Anything? There's the one PA. Or we can all see there's an overhang. It's not the best dental work, but it's fine. What about up top? You guys see anything going on? Okay. Let's move on then. What's her history? She said, my teeth feel a little awkward and I have some sensitivity. That should be a red flag right there. I have awkwardness. The bite doesn't feel right. I have a history of Bell's palsy. Usually when I see people with Bell's palsy, they're pretty droopy. She seemed completely normal, so I'm interested. I still never figured out what was going on there, but something interesting. She's got a lump down here on the lower right-hand side, and antibiotics fixed it. Great. So what do we think that lump was? Guys, what runs all along here? Lymph nodes. Good job. The teeth have some sensitivity, but they're not that bad. She was pissed off from the moment she got in here. Everything. I'm surprised she let us take a picture of her. That's, by the way, that's another red flag. If the patient, we take a picture for their chart on everybody. If they don't take a picture, that's a red flag right there. It's Gary Carr had this thing, and I remember hearing this when I was in residency, being like, "What are you talking about?" And dear God, it's 1,000% true. If they won't take a picture, it's a great tool. It also helps. I don't know about you all. I tend to remember teeth better than I do faces because I look at the teeth a lot more than I do at their face. So having the picture in there is kind of helpful if they're like, "Oh, do you remember so-and-so?" It's like, "I remember the tooth. Oh, they look like that. Yeah, I remember them now." But I'm surprised she let us take a picture, but she was just angry. And so upon examination, she was extremely grumpy. Yes, no, in all of her interactions. She didn't look me in the eye. She definitely was overweight. And when we look at her clinically, the soft tissue, huge tongue, breathing through the mouth like crazy. She had a ton of work done, but it was gold. I will say gold can still cause these issues, but it's much less likely to because gold's so soft, it'll deform over time. So it'll hurt for a little bit and then it will go away. When she would open, she had a decent amount of deviation and had clicking with reduction on the TMJ. Both of the masseters were very enlarged and sore, and on the right-hand side, I was able to get trigger points. Guess what happened when I pushed on those trigger points? Referred to the teeth. So it was her mouth earlier that you saw. This is that massive tongue, literally just covering the teeth. When I try to get a photo of the tooth, you can see the tongue is so big that it's covering the teeth. And what I want all of you to start thinking of is maybe her tongue isn't too big, maybe her mouth is too small. We look at the upper teeth there, it looks totally fine. And when I get inside there, you can see the occlusion isn't that bad, but she does have some pretty heavy wear facets. So on fremitus, when you go laterally, you can feel the teeth wiggle. Number 2 was starting to get a little bit wiggly. She actually was so high on her non-working interferences, which remember those are the bowl, the buccal of the upper, the lingual of the lower. She had such hard time, they were so big, she actually had hard moving to the right. And that's why the teeth on the right-hand side were causing the problem, because on the left-hand side, she didn't have those interferences, so she's not creating that intense amount of force. On the right-hand side, it's opposite. Everything else looked normal. I mean, one crown margin was a little overhang, but I couldn't get into it, so whatever. A little more sensitivity on the cold test on number 2, but it didn't linger. The bite was sensitive on number 2. So just to remind you all, if the one thing you take away from the 2 years of lectures I give you is to adjust these damn cusps. I cannot tell. I've done it already 3 times today. I've seen 4 patients today, and I've done it on 3 of them. The other one was a perio case. But for class 1 occlusion, the buccal of the uppers and the lingual of the lowers should not be touching because it's going to cause that fremitus. Give your root canal teeth implant occlusion, and they will do much, much better. It's going to cause those lateral interferences, the fremitus. Posterior teeth do not do well with lateral forces. Posterior teeth are designed, based on the way the roots are shaped, for up and down forces. Anterior teeth are designed for lateral forces. That's why they're shaped like that. The canines are the only teeth in the mouth, because they're shaped like a triangle, that are like a diamond, that are designed to take forces in every direction. That's why I do whatever I can to save canines, because they are, in my opinion, the most important teeth in the mouth. What you will find is that this is way more common with those harder materials. We went over this last time, but it's important enough that I'm repeating it for all of you. And this is why we didn't tend to see this as much in the past if you talk to the older dentists, because they were primarily using gold or PFMs. PFMs are a really soft material. Think of how many times you look at a PFM and they've worn through the porcelain all the way down to the metal. And what would happen is if there were these interferences, it would be sensitive for a couple of weeks. And if you ever worked for a dentist, they're going to tell you when you cement a crown, totally normal to be sensitive to biting and cold for the next couple of weeks. It's just your teeth getting used to it. It's your mouth getting used to it. What it actually is, it's your mouth wearing away all the interferences that they didn't check for. The problem is Emax and zirconia are so damn hard, they're going to take all the force from those interferences and push it into the teeth themselves. The other thing that we kind of talked about is that all these crowns are designed digitally. And when you take a scan like they did on my upper jaw, it's static. There are ways to do it, but they're not doing it on articulators. They're not doing it where you can see the movements. They're not checking these things. The prosthodontists are when they do 28 teeth, but most people, if they're just doing a single crown, they take the scan and they tell you to bite. That's your bite registration, and they're done. So the computer makes beautiful looking contacts in straight occlusion. It then wants to make sure everything's touching. So it'll take those buccal cusps and drop them down super far, and it'll take those lingual cusps and drops them down super far, and all of a sudden, everything's touching in what appears to be an ideal occlusion, but as soon as you put movement into that, now we have problems, and that's why it's usually these materials, and it's usually these cusps. So what do we do for this lovely lady? We adjusted the buccal of upper and the buccal of 2 and the lingual of 31. She was bad enough and her joint was starting to cause some pain that I did send her off for an evaluation. I don't think she ever went because she felt better after this. Talked to the general dentist that she could probably benefit from like an anterior-only night guard. We gave her those physical therapy exercises. I'm happy to say this was over 2 years ago that I saw her, and we still have no treatment on her. So what I want you all to take away, look beyond the teeth during the exam. Breathing is incredibly important. Once you start to notice this, it's one of those things you're never going to be able to unsee it, and I apologize. It's kind of like The Ring. I have to show this to everybody or I'm going to die. Now, I need you to go out and show it to other people as well, and just start noticing how many people have issues with breathing. Notice the posture, the head as it's coming forward, check the muscles, and make sure you check out that tongue as well. All right, so for next time, we did make it. I'm very proud of all of us. I got 2 more in the kind of, anxiety thing, and then we'll go into the whatever the heck you guys want me to talk about. But the next 2 we're going to do are either pharmacology or local anesthesia. This is going to be applicable not just to our patients with anxiety, but to all patients. For pharmacology, we'll go over the most common medications that I use, kind of give you a short version of the little dental drug booklet just for endodontists. And for local anesthesia, we're going to talk about how I give anesthesia with as little pain and stress as possible with the most predictability, and kind of the techniques of all of those for every tooth in the mouth. What would you, they are interchangeable. What would you like to hear next time?
Local anesthesia.
That's what I thought. You're like, Scott, it's been 3-4 lectures now, and we haven't had one single clinical thing. So I'm happy to do local anesthesia for y'all next. Cool. Let me go ahead and stop sharing that. Right. Cool. So we actually have a few minutes. We can either, I took a few pictures on that patient this morning. We can go through a couple different ones if you want to do a few more examples. But does this seem to make sense to everybody? Is this something you've thought about or seen before?
Definitely, yeah.
Yeah. It's unfortunate. Once you start seeing it, you're going to be like, damn it, Scott. We're seeing it more. Yeah.
So what kind of like diagnostic tools do you use to like initially diagnose the severity of your OSA?
For me or for my patients?
For you.
Oh, I've had a professional sleep study by a pulmonologist. I've had 2 take-home sleep studies. I've had my own sleep study. I use my little ring here is an Oura ring, so it tracks my sleep. That's what I kind of use for a day-to-day one. Snoring, there's a thing you can get on your phone that will record you and say whether or not you snore. Did I catch it all? A lot. But there's no one, like, yes, I had to do the professional sleep study because I knew I was, so I was okay. Like, I was starting to see some improvements with the one mandibular advancement device, but it was starting to cause a ton of pain in my jaw. Like, my muscles were out of control all the time. And it was affecting the bite, and I was just, I was tired of it not, it helped make it so I could sleep okay, but it wasn't good sleep. And so that's when I came up with this idea to use SFOT, because usually all they do is widen. If you want to widen teeth, this works great. Works extremely well for it. It goes about twice as the orthotherapy goes about twice as fast. It's incredibly predictable. Most of the orthodontists who are using this now are doing it with Invisalign. They don't even have to use traditional brackets because it's so predictable. Because what you do is, when you make those cuts, you're pretty much turning the patient back into a kid with open sutures, and you're making it so that they have 14 open sutures all the way around the mouth. And that makes it so it's very easy to move. Instead of having to move the teeth through the bone, you're moving the small little chunk that contains just the roots of the one tooth into spot, and it moves the bone with it. So it's a much faster and more predictable movement. But in order to do that, I wouldn't be able to wear my appliance anymore. So that's why I started wearing the CPAP, was because I knew I would, while I was doing that process, I would actually go back as far as the quality of sleep and kind of the other things that I was measuring. And so by having the CPAP, I could make it so that I would have the continuous flow of oxygen, so I wouldn't be, desatting during the night, which this does catch, which is kind of cool. And that's kind of how I started. But the sleep isn't great with the CPAP. Like, you wake up and you feel like you're still tired, but you also feel okay because you didn't desaturate, but you had like a giant fan blowing on your nose all night long. It's a weird sensation. It's not good sleep, but it's better sleep than if I was, trying to do it normally. So after about 3-4 months of movement, I started to see some significant changes. Like, I don't know if you can see, but I'm about 2 millimeters open. Can you guys see? Like there's a gap now because my maxilla has moved forward. My nasolabial folds have actually, they used to be a lot deeper as well, and those are moving forward. So I have noticed some structural changes. I'm actually due for a cone beam to actually have them go through and do a lateral ceph and figure out if I have had the movement that I think I have. And so after a couple of months, I started trying to drop off the CPAP, desatted almost immediately. And so after 2 more months, I was able to pretty much drop it off. And I only when I have a lot of fun with friends over do I still wear it, because alcohol does make you make the tongue relax a little bit more. But besides that, I don't wear it at all. Yeah.
How was the breathing through your nose before compared to now?
Oh, dude, that was one of the biggest. That has actually made one of the biggest differences, is the Vivera procedure. I would find when I would run, especially if it was colder outside, and try to, by the way, if you exercise, you should be breathing through your nose 100% of the time. Unless you're doing full on, like, Olympic level sprints, you should be able to get enough air through your nose. And so after learning this, I would start to try to nasally breathe only while running. And I would find after, God, even half a mile, my nose would literally be burning. Like, I couldn't get enough oxygen in. I'd be pulling so hard through the nose, it would literally be burning. And that made just changing the nose, before we even did the advancement devices, before we did anything else, I didn't change a single habit, and it dropped 10 pounds. Like, insane how quickly. And the reason I kind of do the scale is a really easy measurement. That's why it's a very quick one to do. But what you'll find is if you don't sleep well, everyone remembers college, and you stay up too late, and then what are you hungry for the next day? The shittiest food possible. carbs, grease. Think about the hangover cures. It's bacon, it's heavy stuff. And that's what happens. There's actually different hormones, and that's what they kind of go into in the Why We Sleep book. If you want, I can put together like a 5-minute thing on it. But the different hormones that affect your hunger and satiation, like your ability to feel full, get screwed up when you don't sleep well. And that's why they're starting to think that it's not that obesity causes you to have breathing issues, it's that breathing issues causes you to be overweight. What other questions you guys have? Did you learn any of this in school? We learned none of this in school. That's why I'm curious. Like in dental school?
Not to this depth.
Yeah. This is like barely touching the surface. If I show this to the group of the ADA, they're gonna be like, dude, you barely touched any of this. Like, what the hell are you doing? You didn't talk about nutrition. You didn't talk about ultra processed foods. But to kind of summarize, what's happening in this country is we have And the reasons that we have issues, I'm not sure why we see so many ties, but there's a lot of tied tissue. If you look at frenum ties on the lips, on the tongues, you'll see there's a lot more patients that have them than you think. Not sure why that's causing. I do know for sure the breathing issues, and that's because our air isn't clean, our water isn't clean, there's pesticides everywhere, we can't literally go out, there's fires all the time, there's allergen, there's all these things that are causing it, so we can't breathe like we used to. And what you're seeing is with those morphological changes, that was the one study I forgot to put in there, is that we didn't see malocclusion until the Industrial Revolution. It wasn't until we started to have these massive amounts of pollutants in the environment that we couldn't breathe properly when we were kids, and that leads to a lot of the retruded mouths. So until, I mean, everyone knows about George Washington and his teeth. That was perio. After the 1900s is when we started, and the Industrial Revolution kind of started, 18 to 1900s, depending on which part of the world you're in. That's when we started to see the jaws becoming a lot smaller. This is why we have wisdom teeth. If we lived in an ideal world, we should have enough space for our wisdom teeth, but we don't. And Chris is able to make a lot of money taking those out because there's not enough space for them anymore. And why is it that some people not only need their wisdom teeth out, but they also need bis out, and then they still need IPR, and then they're farther back, and then they're just set, and that's the other, always check for extracted bis. Excuse me, that's another one you'll start to notice that those patients tend to have a little bit more problems as well. And so you put all that together, plus we have a more calories and shitty food available to us than we've ever had in the history of the world, at cheaper rates than we've ever had in the history of the world. And it's just it's a recipe for terrible, terrible things, which is exactly why we have huge amounts of the American population with metabolic syndrome, with all these issues. It's why our healthcare costs are so high. And if we don't fix it, we're literally going to run out of money. So if you guys want to know more about the nutrition side, I'm friends with Robert Lustig out of UCSF. He's got like 5 different books. He's a pediatric endocrinologist who, similar to me, I got into this because I was interested about patients who had this weird pain that didn't seem to make sense based off of all of them. He got in it, and all of a sudden he's treating hundreds of kids with diabetes who are 4 years old and trying to figure out why. And so he comes at it from a more nutrition, added sugar, that sort of thing. But all of his work is absolutely fascinating, and he's a really good dude. Other questions? We got time. My kid's not here. Where is he? Yeah. I got time if you guys do.
Did you wake up with a dry mouth all the time?
No, because I had mouth tape. So
you would never break through the mouth tape during the night?
I would have to so when they first, if you guys haven't known the mouth tape, it's micropore tape. It's 3M micropore tape. It's the cheapest stuff. It works great. There's a bunch of influencers who are selling their snore tape and all this other crap, and it doesn't really work that well. It's very expensive. Just get the 3M micropore tape that I guarantee we have some in the office for when Chris does work. It's in every medical office. But usually how they tell you to do it is you fold over one end so that if you do need to get it off, it's a lot easier. I would literally push it all the way, get it flat, and that way I wouldn't be able to get it off. Otherwise, I would take it off for sure. Yeah. Sometimes it's actually hard to get it off, but you can, if you push really, really hard, you can pop it off. But usually that plus the little, if you have the XLEAR, it's called clear spray. Stuff works incredibly well. I would recommend the capsaicin one. It doesn't burn, even though you think it will, but it is able to open up your nose almost immediately. I actually had a sample of it after the ADA thing, and it was right as we started to have more and more allergies pop up in Reno. And my one staff member was just sneezing like crazy. I was like, I know it seems crazy, just spray this in your nose. And it literally fixed it. And now she's also a big fan of it. You can get it on Amazon.
It's called Clear?
XLEAR. I can text you guys it too. But yeah, it's great stuff. It works really, really well to open up the nose. I usually use it right before I go to bed. I make Evie use it, even though she hates it. My wife won't use it. Well, maybe I can. If one of you can become a TikTok influencer and tell her it'll make her prettier to use it, I would appreciate it. She's gone, so that's okay. I'm safe. She just dropped the kids off, or just dropped by to say hi. But yeah, yeah. No, that stuff works really, really well too. And what's interesting, one of the earlier Jeff Rouse things is he kind of back then they were talking about kind of the initial stuff, and I've taken his course since then, and now he's gone through this process as well. So this is a guy who used to have the appliance, and back in 2016 he had actually just had this done because he was really, really narrow, so he needed expansion this way, and he kind of talked about why he did it, and it's the same thing as me. This is the guy who literally was known as the mandibular advancement device. That's what I knew him as back when I started on that little forum back in the 2010, 2011, is he was talking about all about how far you push it forward and how you titrate and all this sort of thing. And he's like, I'm known as this guy, and I hate it. Like, I don't want to have this thing. I don't want to have this thing for the rest of my life. So how do we actually fix the problem? And for most people, and what he did is he kind of developed this it was called the Seattle Protocol. And you can still look it up. He's kind of changed his ways. I was at Spear last year, and he's actually changed it since then. But the idea being, there's patients who are pretty mild, and they can be fixed just by mouth taping and spraying. And that takes care of the problem 90% of the time. Some of them, to fix it permanently, might benefit from having the valve expansion, from having some nasal stuff done, and they're good to go. And that's most people. If you can just get them to breathe through their nose properly, it fixes and reverses a lot of the problems. I don't know why I didn't get fixed with this. My best friend from dental school has also been involved in all of this. He had an earlier version of this called the dome procedure, where they go in and they make cuts all the way up here on the maxilla, and it weakens it, and then he splits the palatal suture, and then he had an expander that opened him, I think 1.2 centimeters. So he had a space like this big between his front teeth, this huge diastema, then finally closed it after the bone healed. Then he had to go in for a maxillary mandibular advancement because he still had issues. But his problem was never the metabolic syndrome. He had terrible GI issues. Terrible GERD. Was taking all the drugs all day long. When we were in dental school, there were days he couldn't go into school because he was in so much pain, and he was like guzzling lidocaine because he was in so much pain GI wise. So there's a lot of open questions to this, which is why I think it's easy to kind of attack it. It's like, why is it that I get the metabolic syndrome, but Mike ends up having GI symptoms, and my daughter has emotional issues, and some people have no problems whatsoever? It's still a lot that's out there, but for what I want all of you to take away, if you guys want to talk about this more, I'm happy to, because it's awesome. But just to bring it back to clinical stuff, start looking for these things, because they're the patients who are going to need that extra TLC. They're going to need some more medication. They're going to need more anesthetics. They're going to need probably sedation. They're going to need more post-op care. And that's what I want you all to take away, is how to identify these patients. And this is probably one of the most useful ones. Cool. Any other questions?
What did you say actually fabricated the devices for you, the expansion devices?
Oral facial pain doctor in town, a friend of mine.
So how do they determine like the endpoint, like how much expansion, how much protrusion, whatever?
Well, I'm making this up. That's the other thing to consider here, is this is all me making it up. So we're pretty much going to go until I don't have any issues breathing wise, and I can ideally get off all the hypertension medications. We're starting with the maxilla because that's so important for the nasal floor and for breathing. Once we've developed enough space for the tongue, we're going to redo the frenuloplasty. That was the reason it came back, by the way, is when Chris was the one who did my original surgery, we didn't do any PT after. We didn't do any myofunctional therapy. So if you don't fix the way that your tongue behaves, that collagen is going to grow back. That type 1 collagen that's impossible to stretch out, it's going to grow back. So you want to first create the space so that the tongue can get into there, and that's what we're doing right now, and we're close. I can almost fit my tongue into that massive space that you see. And once that's there, I'm already starting to do some myofunctional therapy now because the appliance is out, because they're making me a new one to fix that, the other teeth. And then once that's done, we'll do the tongue, hopefully get that in the right spot, and then we'll move on to the mandible and get that into the proper occlusion. And then eventually I'll go through ortho, and 5 years after I started, I might actually have a bite that's stable. So cool.
Jacob just bounce because we have.
I was gonna say you guys are way. I was going after you. I'm happy to chill, but if you guys need to go, do it. If you want to continue this via text, I'm happy to answer all questions. It's a super interesting concept. I talk about it all the time, but thank you guys so much for the really good questions at the end. I promise we'll do clinical stuff next time.
This was great. Yeah.
Good. Okay, I'm happy to hear that. It's yeah, like I said, it's go ahead and talk to Ortho and Pedo. I'm interested to see what they say about all of it. It should be interesting. Yeah. So, all right, guys, have a good rest of your day.
You too.
Bye.